others will be joining us. So, good evening, everyone. Welcome to Medical Mondays with Dr. O. Whew. What a few weeks it had been. It's been an interesting season where there has been multiple suicide attempts, suicidal ideations, and actually completed death by suicide. So I am Dr. Toyin Okwesomi, a family practitioner, HIV specialist. I also treat substance use disorder in Maryland. And I am the hostess of Medical Mondays with Dr. O. Tonight, we have the privilege of having our very own brother returning from London. It's after 12 midnight. It's 12:06 a.m. in London. And he had, agreed to, come in and educate us on these life-saving measures. We have the honor of Dr. Ayodele Ajayi, who is a consultant psychiatrist, lead mentor into medicine, and the convener of Tripart Care Mind Gym courses and hub, which I attend every last Thursday of the month. I shared his link this last Thursday, and I've shared it before in the past. The link remains the same. Topics are different. And he also has a YouTube channel where you can catch all the previous episodes of Tripart Care Mind. He deals with in-depth mental health issues that are very much needed in our communities. So without much ado, I welcome Dr. Ajayi and I yield the floor to you. Thank you so much for according us this privilege. God bless you. Thank you. And he's going to be talking, on suicide prevention. Thank you.
Thank you so much. Can everyone hear me? Can everyone hear me?
Yes, please.
All right. Okay. All right. Thank you so much, Dr. Ho, for having me back. It's always a privilege to be here. The last time I was, it's probably a couple of years ago now. It was, I felt really very welcomed, and I had a great time. So thank you for having me back, Ma. And I just want to start by saying that to express my sincere condolences and empathy to the community in terms of what's happened in the recent times. Every suicide is a major disaster, is an indictment against community. It's a message, it's a very strong message to community that somewhere along the lines, we've dropped the balls one way or the other. And it's a great thing that we are doing this. And I also want to celebrate the work that you do for Dr. O. I can imagine what effort goes behind the scene in terms of always showing up every Monday to produce this event. And only God knows the impact it's making. Only heaven will reveal that to us, the impact, the life-changing impacts. Sometimes many of these things we never know until who knows. So thank you, Ma, for what you do. I'm just going to, and I just want to say thank you to everyone for coming tonight. And I'm just going to share my slides. I aim to do quite a bit, to go through quite a bit of content, but I'm aware I've got 45 minutes, so I'm going to be quite, I'll be on the ball with that. Right. Okay. So the title that I've given to this is suicide prevention. There's no doubt, but over the years, over the last year or so, I've begun to see suicide prevention as a collaborative issue. It's a societal issue rather than a mental health issue alone. Because many times we look at suicide and we think, oh, it belongs to the remit of mental practitioners, general practitioners, family physicians, counselors. I can see Sister Rosemary is in the house. And we think that it's those who are qualified who need to do it. It's even sometimes I hear some of my other colleagues say, oh, yeah, it's your business. But interestingly, over the last year, I think the suicide prevention event that we hosted September 2022 at Tripad Care, I don't know where that concept came from. It just struck me that actually we should be looking at a collaborative approach. Interestingly, this year, the UK suicide strategy, the suicide prevention, the National Suicide Prevention Strategy for England was then released on the 10th of September. And guess what? They start talking about a collaborative approach. And I'm thinking, oh, wow. So there's something about collaboration in terms of suicide prevention. And the thing I feel is becoming more relevant is that actually it's not just the statutory organizations, it's the non-statutory organizations, it's our community, it's our churches, it's the places where we meet people, where real people live, real people interact, real people have dialogue, real people play out our lives. Those are the places where we really need to be looking at, because no matter what strategies is national, what national strategy, regional strategies we have, we need to, it's important that there's an inward look and that everybody can play a role in suicide prevention. Usually I do disclaimers every time I speak in public domain, but I always say in certain domains that I know I'm in comfortable zone. I know I'm in the family, in the midst of friends and family, so there's nothing to worry about. Just to say for statutory purposes that this is a public mental health information exercise, and it's not a personal consultation. And anyone that is important to consult with one's own main provider, mental provider, or professional health or health provider to make decisions. And it's also apparent that this event is being recorded. Right, so let's start from here. This man, Professor Louis Appleby, I'm sure those who work in suicide prevention would know that name, is the guru or the Caesar of suicide prevention in the UK, and he's got a global name. This is what he said in this is his latest, I think this is his latest statement regarding suicide prevention, which is in the England suicide prevention national suicide prevention strategy, which I said was released on the 10th of September, just about 2-3 weeks ago. It says suicide prevention starts with society's values, breaking down the shame that determine from seeking help. And that includes ourselves. We are the people, we are the ones who are members of the community, who are members of society, and we can really make that happen. And it says that it also would prevent offering young people opportunity and hope. I was glad this evening when I was looking through the CDC figures for suicide statistics in the United States to see that you people are actually ahead of us in terms of preventing suicide among young people. I was glad to notice that there was a drop between 2021 and 2022 in the suicide rate between the ages 20 to 24 years. In the UK, it looks like that's something we are grappling with at the moment, because we are finding out that suicide rate as among young people is something that is quite worrying. And in the national, there was a survey carried out post-COVID, actually intra-COVID and post-COVID, that also showed that actually the 18 to 35 age group were the ones who were most adversely affected in their mental well-being as a result of the lockdown. So, and that's something I always say, that many times we focus on the middle-aged man is the boss person that we think about when we think about suicide. But our young people as well, who are experiencing life events, going away to university, even going away into the world of work and all that. But the point from this slide is really that one, there are three things that this talks to us about: our values as society, and we are the ones that shape those values. The second one is really that we're offering hope to young people in our community. And the third one is about making it easy for people to seek help. And that's really about addressing stigma. It's really making it possible for people to seek for help. And sometimes it's institutional. Sometimes the way we look at mental well-being, the language that we use, the way the jokes that we crack makes it impossible. It's almost like we're in a setting and somebody says something and somebody is already dying within. They're already screaming for help and taking a chance. Should I not? They hear things like that and they think, I'm going to shut up. I'm not going to let anybody see how vulnerable I am. And in that process, we miss the opportunity of catching somebody on the brink. So I think that's a very poignant quote from Sir Louis Appleby. He's also a very leading national voice in terms of suicide prevention in the UK and globally. So what is suicide? I'm sure in the midst of very learned people, highly qualified professionals, so I know we all know what suicide is, but this slide has been put there with that blue background and that floater in the midst of it. It's like a floater in the midst of the sea. And it's really to say that when suicide happens, it's not just the person who dies who is affected. In fact, the reality is that communities are affected. That's uncles, aunties. When somebody dies by suicide, that's somebody's son, mother, brother, sister, uncle, auntie, a colleague, a leading voice, a pastor of the community, or a church leader, or even a community leader. It's always somebody who's connected with other people. There are various figures that people have quoted, but the common one is that it's in the doubles in the number when we think about the number of people who are affected by suicide. And that's why I think the import is that really we need to do all we can within our remits to make sure that we contribute to suicide prevention, and every one of us can. My conviction is that everyone can prevent suicide. We all have a role to play. We can all do something in suicide prevention. And I think it starts by updating our knowledge. After Thursday's meeting, a very dear colleague of mine who is also a supporter of TRIPACare sent me a video. And I was listening to it on Saturday morning as I was driving to the gym, and I thought, oh my God, this is actually new information that I haven't ever come across. He was talking about suicide crisis. This is somebody who spent the last 15 years or so working in suicide, and about how sometimes we focus on the chronic suicide risk factors, but we don't look at the acute risk factors. And I thought, the import of that is that every one of us, we need to keep updating our knowledge and really being on the ball and getting the information and putting ourselves in touch with what's the most current and leading research in the field. So what do we know currently? One of the things that prevents us from being effective in our suicide prevention bid as communities is the myths, is the misgivings, is the things that we know to be true that are untrue. We hold them as facts, but they are fallacies, and we tenaciously live by them when in actual sense there's no substance to them. Suicide, one of them is that suicide is not preventable. Actually, the figures nationally, I'm sure it's in America the same. In the UK, for instance, what we found out was that prior to 2 decades ago, before we started having a national suicide prevention strategy, that the suicide rates between then, 2 decades ago and now, that has been a 20% reduction in suicide rates prior to that approach, that national coordinated, collaborative approach towards suicide prevention. So it does give hope, because sometimes you've got to have some hope. You've got to go there having a skin in the game that actually this effort is going to pay out. It's going to yield some dividend. So suicide is preventable. The other thing that people commonly believe is that suicide prevention is exclusive to mental professionals. That's our role. And I just want to say to everyone out there this morning or this evening, as it is in the United States, suicide prevention is everyone's business. If there was any one message if there was any way to put a slogan to what I'm saying today, I think I'll have a good, I'll think my job has been done if the slogan is suicide prevention is everyone's business, because indeed it is. All that strategy, all that policy, if it doesn't filter into behavioral change, if it doesn't filter into everyone taking ownership that actually I am my brother's keeper, and that that role of preventing suicide is my own individual responsibility as a member of any community, and every one of us lives in the community. That's the reality. We're community beings. We, one way or the other, whichever way we call it, we belong to one community. We belong to at least one community. Many of us belong to many communities, actually. So suicide prevention is not exclusive to professionals. Every one of us can learn the skills. Every one of us can develop the knowledge, and everyone can grow in it. Asking about suicide that's the other thing. People say, I don't want to ask. I don't want to ask because I might sow the idea. I'm just going to say this now. I had a personal experience, I think within the last couple of years, that reinforced that message to me. I had been reading it in books, but I had never really had an experience, obviously, in my professional life. It's unpardonable not to ask every time I have a clinical encounter. It's unpardonable not to ask that. But I had a community experience. It was just a casual church, finished church service. I'd spoken, and somebody walks up to me and says something. And as I drove home, I told my wife, I said, that doesn't sit right with me. It's just, I cannot shift this thing. I just feel so uneasy about, and it was very flippant. It was such a very, you wouldn't have else much to it. So the next, so that afternoon, as soon as we got to my center, person is text and say, actually, could we talk? And they say, oh yes, we can talk. So I say, so we're able to have a chat the next day. And it took all my guts, despite the fact that that's what I do on my bread and butter job, to ask them that, have you considered not being here? The worst I expected to hear was that they were going to say, actually, I've been thinking about it, but nothing, don't worry. But that's not what I had. What I had was that actually I've been thinking about it, and that within the last 48 hours, I was on the verge. I actually got myself ready, and I thought, yes, this is it. That shocked me and shook me. That began a process of recovery, but thankfully, thank God, we've got that behind us now. But it's just to let us know that you never know when you're going to ask, and it's going to be that actually asking was a lifesaver. Because by the time you ask, if somebody has suicidal intent, they are hoping that somebody asks them. They are really hoping that somebody asks that question, because they are so. None of us want to walk out of life with all we've invested into it. For somebody to make a decision that taking their life is the only option left, it's because they're on their last card. It's because they are really, really, they've had it, and they can't think of any way out. And any iota of hope at that point can really be a game changer for them. So asking about suicide so it doesn't give people the idea to ask, act. It doesn't, it's not an attention-seeking behavior. I know in our Black communities, I don't know what happens in the States, but in the UK, in the Black diasporal community in the UK, sometimes the way people talk about mental well-being, it's like people are just playing gimmicks or putting it on. But the reality is that societal distress is a real thing. And this is something that people are grappling with, and it's not a cry for help. And even if it was a cry for help, it's because there's a need for help. I mean, somebody who is not, you don't hear people cry for help except there is a need, or they perceive that there is a need. So the point is still that we do all owe our community a responsibility. And the other thing I say is that, how do we know? People say, "Oh, it's a cry for it's an attention-seeking behavior." I don't know that. I'm not sure. I cannot categorically say at any time that because sometimes we get it, even professionals get it so wrong. So it's always better to hear on the side of caution. Every suicidal death was from mental illness. That's also not correct. We do know that depression, anxiety, bipolar disorders, substance misuse disorders, even now people are talking about autism, and that all of those things increase risk factors, schizophrenia, psychotic illnesses. But the reality is also that there are also people that it's just life that has happened to them. Life has happened to them and pushed them on the brink. So what do we know about suicide statistics from the World Health Organization? We know that every single year, and this is every single year, not 2 years, not 5 years, not 10 years, not 20 or 40 years, every single year. Let's think about what I said earlier in terms of every single death by suicide is somebody's uncle, somebody's aunt, somebody's brother, sister, mother, father, son, daughter, colleague, pastor, leader, mentee, mentor, corporate leader, community voice. Every single year, 703,000, about that number of deaths to suicide we have globally. And it equates to about 1 in every 40 seconds somebody takes their life by suicide, and 1 out of every 100 deaths is by suicide. And that's actually annually 20 million people try attempt their lives by suicide. That's about 1/3 of the UK population. That's the magnitude. And we still know that men more than women. It's still a 3-to-1. I was checking the CDC figures tonight, and actually it even looks like the CDC, the American figures are even bordering more on men. I calculated the figures, and it's about 79% to 21%. 79% men, 21% women. So our men are still to be focused on. And I want to drop this as well. In the last 2 years, since I really got more involved, it's always been something I've been involved in, but since I've been more structured and more involved in community mental health education and mental health coaching, I've actually found that it's a myth that men don't talk. Or Black men don't talk, men don't talk. It's a myth, because that's not been my experience. What I'm finding is that when men find that there is psychological safety and that there is a space where they can be sensitive and they can feel and be vulnerable and let down their guards, men actually talk. Every week I have men who talk to me, who spill their guts about their mental problems or about their distresses and about is that from me? Hello?
No, not from you. Not from you.
All right. Okay. So all right. Okay. So every week I have, and it cuts across board. People say, "Oh, middle is Gen Z Black men are more in touch with their emotions." I think they are. Honestly, I really think they are more psychologically aware, more psychologically minded than we are. Or it may just be that over the years we've been so avoidant, and so we've built up so many layers of protection, so many layers of what am I looking for here? So many defenses, so many forms of primitive defense mechanisms that denial, in form of denial, that our emotions are so cocooned. But the reality is that I found out that men actually talk. When men feel safe enough, and if somebody creates the space, men will come and talk. I know that Dr. O would attest to that for some of the things that happened on Thursday, where every one of us were just dumbfounded about the content that was being exposed on that day. So these are all figures from the UK. This is the American figure for suicide. This is from the CDC relative. This is comparing the 2021 to 2022 figures, and basically we can see that is staggering. That figure is almost 50,000 suicidal deaths in one single year. I think we should just allow that to sink in. That's 50,000. Men more than women. It's almost like 80. It's almost like 4-1 really. In this case, percentage rise higher. Now, the other thing is that actually, the CDC says that the rates increased more in women than in men in that year. So even though on the overall, more men are still dying by suicide, but actually, relative to last year, 2021 to 2022, more women died by suicide relative to men in terms of the increase. So when you look at the gender figures, and that's something to pick up on. Also, that American Indians and Alaska Natives had a 6.1% drop. So what are they doing? I mean, Dan Buettner, when he started looking at longevity, and he found out that there were certain communities across the globe where the number of people who scaled over the age of 100, they had a higher population, and there was something about them. He began to study those communities. So the question is, what are the Native Americans and Alaskan Indians doing? The American Indians doing? To have 6.1% drop in 1 year is significant. It couldn't have been fluke, except the figures, except the survey. If there's something, there must be something. African Americans, 3.6% rise, and I think that's obviously will be of interest to us on this group. It still remains the case that the 45 to 64-year-olds still remain the peak rise category, even the most recent. And like I said, I was quite glad to see the fall from among the 20 to 24-year-olds. So what are the risk factors? We all know this already, but it's always good to look at to refresh our memory. We've talked about men more than women. Previous suicide attempts, 58% in. The other thing is actually globally, the World Health Organization says that most of the suicide, when we look at the global figure, occurs, more than half of them occurs in under 50s. And a family history of suicide is an alarm bell. 3 in 4 suicides take place in low-income and medium-income countries. Psychosocial stressor, alcohol and substance misuse, those are things that a neighbor can spot it. Somebody can spot that a member of our community, whichever way wherever we meet them, that there's something about them that we think that gives us the idea that they are using more alcohol than they used to, or that maybe they're beginning to use drugs. There's something that is glazed, that their eyes are glazed. There's that young man that you just begin to see that is more aloof. It's not always like it's with it any longer. Those are things that can be alarm bells. And of course, mental conditions, depression carries a 20-fold increase. In fact, there was a European study that showed that they looked at they did a retrospective study and looked at postmortems and postmortem and medical records, primary health records of a very large cohort. I think it was over 20,000. And what they found was actually that more than 50% of them, I believe it was a Danish study, that more than 50% of them had a history of depression at some point. Chronic pain, living alone, loneliness, isolation, poverty, being on the fringes of society, ethnic minority, and whatever other criteria makes people feel that they're on the fringes, that they don't belong, they're not mainstream. So what do we know works in suicide prevention? We know we know that it's possible that there are evidence-based methods that exist, and that evidence does show that it's possible. Like I said about the things that we know from the UK, for instance, community support to combat loneliness. That's something that we know works. And responsible and sensitive media portrayal of suicide.
It's called.
I always say that one of the reasons why I actively engage with the media, a lot of my colleagues don't agree with this. A lot of my psychiatric colleagues are actually they have a suspicious relationship with the media. But the reason why I engage with the media is because if the media needs news, they need news. That's their game. That's their business. That's what they thrive on. So one way or the other, the show must go on. There's no doubt about that. So from any source, so they will fish for news and look for news. And so I might as well engage with them and make sure that at least the information that they're getting is credible information. Because every single day in consultation, I hear people who genuinely go to information sources, believing that what they read was factual and was credible and was truth, and they're living their life by it. Yes, yet nothing could be further from the truth. So it's very important that professionals who carry clout, mental professionals, primary care physicians, counselors, psychologists, that we are out there really engaging with the media, because the challenge is that the media don't know the difference. So we might as well step up the plate, put ourselves forward, and make sure that the misinformation, we combat misinformation by putting truth out there. And that's one of the reasons why I do it. We do know that the media is a very strong, particularly these days, social media is another one. So it's important that one of the things that everyone on this platform can do today in terms of shaping, contributing to suicide prevention, is that wherever we have the opportunity, wherever we have clout, wherever we have influence, every one of us is an influencer. That we determine the conversation, we move the dial in a way in which credible information is being shared with the public about mental health and mental well-being. Local education to create community awareness, that's also something, that's what we are doing today, and we've continued to, Dr. Uwas continued to do. Restricting means of suicide does also help. The other thing, according to the World Health Organization, which is more recent, is that actually they're also talking about fostering life skills among young people. And that's why I'm sure there are people on this call tonight who work among young people, maybe you're a youth worker, youth pastor, or somebody who works in the Sunday school, or somebody who even runs a charity or an NGO, non-profit, non-statutory organization supporting young people. I celebrate the work you do, because we now know that those pieces of work can actually be effective in helping young people to develop the life skills. When they fail their driving test, or they don't get their first job, somebody can be there to let them know that it's just the beginning of life. Life will not end because of that. London Bridge will not fall because the other one that is actually being common, that's been recognized, but it's even more commonly being recognized now among young people, is when they have a love rejection, or maybe they are being cyberbullied. But the point is that helping young people to develop life skills is actually something very important. And as we all know, early detection and giving support to vulnerable groups. So I'm going to attempt to show, Dr. O, will that be okay to show a YouTube video?
Yes.
Are we able to? All right, okay, good.
Yes.
So let's try, and I'm just going to try and do that. Now I'm going to stop sharing, and I'm going to see. Stop sharing. Good. I'm going to see one. This is just.
Are you able to share?
Yes. Right. Let's. Okay, good. So looks like we're in business. I'm going to share now. Good, brilliant. So, can everyone hear that? Can we?
Oh, we don't.
Does it doesn't have volume?
No volume.
All right. Okay. Let's do that again. Yeah. Okay. Good. Share sound. That was the problem. So it should. Okay. It should have volume.
A simple smile can mean.
All right.
Now we hear it.
Brilliant. Good. Okay.
What's in a smile? A simple smile can mean little to you or I. But to someone thinking about suicide, it can be the first step towards life. Suicidal thoughts are complex. No one knows exactly what works to stop another tragedy, adding to the 800,000 suicides and 20 million attempted suicides a year. We do know, though, that certain actions can make a difference. And we know that if we put a wide range of these actions in place, we have a better chance of preventing suicides. Community support to counter the isolation so often felt. Responsible and sensitive media portrayals to help people see how others have managed. Local education to create awareness in the community. Restricting the means of suicide to stop people at critical moments. All these actions have been shown through research to work. But we can't do all this alone. We need people on the ground to help us make the first step towards those with suicidal thoughts. By stepping closer, we can be aware of those around us who need help. By stepping closer, we can encourage those with suicidal thoughts to reach out. By stepping closer, we can support those in need by sitting in their pain. Every step closer can connect someone to life and the help they want. Sometimes those steps are big. Sometimes all it takes is a smile.
Right. Okay. So I'm going to stop sharing again and then go back to. I was wondering what our thoughts are. What did it feel like listening to that video? Any immediate responses? I mean, I'll go first by saying that I've listened to that video over and over again, and the message that strikes me tonight is that the World Health Organization is saying to everyone here, myself inclusive, every one of us, that we actually need people on the ground to step closer. He said, with all these policies, smile, that with all these policies we are making, with all from the international level to national to regional to community levels, we still need people who are going to step closer into other people's pain, into other people's lives and deliver. Thank you for those comments. I can see advocate for social emotional learning in school curriculums. Great, smile. Any other thoughts about that video? I think smile is a very powerful one. It's amazing how a smile can really disarm somebody and really give them some courage and hope to face tomorrow. Any other thoughts on the video? Okay, whilst we are doing that, I'll just go back to my slides again.
Bridge distances.
Bridge distances. Thank you, Dr. O. Yeah, bridge distances. Yeah. And we can all do that. We can all break distances, and it's within our gifting to do that.
Somebody wrote, "Get back to being the village that raised children."
Absolutely, I couldn't agree more on that. I like that. I really like that. Thank you for that. Yeah, yes, the village that raises children, because this is sometimes you meet children and young adults and you're wondering which village were they raised in? I mean, what was the village doing? but never mind. So, the next point would be about recognizing the signs. And I also am aware that I don't want to be guilty of teaching grandmothers to suck eggs. I know it's something that it's bread and butter for us, but it's always good to remind ourselves. Change in personality and behavior, I think, is one. And now anxiety states, irritability, feelings of agitation, sleeplessness are actually they are beginning to occupy a pride of place in suicide risk assessments that really what's happening in the suicidal mind at the time when the attack takes place or just before the attack takes place. And anxiety is becoming a prominent one to look out for, where people are just wound up and agitated, and it's almost like a cold spring. Social withdrawal, substances we've talked about, feelings of being trapped, final acts. People start giving away their pets. They start making plans for their children, or start really putting their house in order for no apparent reason. And that's always something to think about. When that's happening, it can raise alarm bells and be your keep. Yeah, it can be something. It can be the first hint that maybe not all is right or well. Appetite, sleep, and energy changes. It could be increase or decrease. Right. So the Samaritans, this is what they've said. They said there's a shush method, and that those are it's like an acronym to help us to think about how to support people who are suicidal. One, to show care, really, and that's what we've been talking about all this morning. Have patience. It sometimes takes time. Sometimes it's good to follow our gut instinct. If we really feel that something is wrong, sometimes we need to hang in there. And when people say, "Oh yes, everything is okay," sometimes it's actually that they're wanting you to hang in there. They're testing your commitment to care. They're just wanting to know, if I spill my guts, am I going to be kicked in the guts, or are my guts going to be protected? Use open questions. So without being judgmental, without also assumptions, just open questions. Tell me more about that. What does that feel like? Without really just really, and then saying in the back, summarizing. This is what I understand that you're saying. Am I wrong or am I right? Please let me know if I've got that wrong. Summarizing can be very powerful because it sends back the message that this person is listening, and it can actually promote further therapeutic relationship or further vulnerability from the person, and then having the courage to ask. Since my experience 2 years ago, within the last couple of years, I've decided that it's not going to cost me. The worst that will happen is that the person will think, "Oh, it's been obnoxious. How could he be asking me such a question?" But I would rather that than then 2 days later, I hear that I was the last person that had the opportunity to have this conversation, life-saving conversation with that person, and I missed it because I had the gut feeling, but I decided to override it because I wanted to preserve my own pride. So this is something that was devised by Tripart Care. It's just another way of looking at having that conversation with people who are in emotional distress. Authenticity, really bringing our true selves. It's one human being to the other, one caring person to the other. We don't have to be mental professionals. We don't have to be primary physicians. We don't even have to have any qualifications to be able to have that conversation. And it's about being open-minded, not being cautious, not to jump into any conclusions, to listen to the distresses, and to aim to offer non-judgmental support. Confidentiality, that's the third one. Very, very key in our communities. People don't want their most intimate matters to be spilled out or to even be said to anyone. When I have these conversations at any time, I will usually say that your confidentiality is preserved, except there is a life at risk, either yours or somebody else's. And at that point, we would both agree that confidentiality needs to be broken. And I will let you know that I'm going to break it, and this is how we are going to break it together. Distractions, thinking ahead, phones. This is number one. This is number one distraction when it comes to the modern day entrance to having those conversations. The TV is the next one. and exchanges, we need to be willing to give something about ourselves, to come in with vulnerability as well. It's not that we're going to make ourselves the main focus of that conversation, but to let the other person know that I'm also human and I've got my own challenges. It's not the day to speak about them, but just to let you know that it's okay to let down your guards. And friendliness, really being friendly in that conversation. And every time somebody spills their guts to me, every time somebody says something that I know is taking them the courage to say it, it's taking them, they've gone beyond they've gone beyond their natural restraints and giving me something personal to them. I always say thank you. And that's because I'm genuinely grateful, because they don't have to, because that single act tells me that they trust me. And I want them to know that they trust me and that trust is not going to be betrayed. And I celebrate that as well. Thank you for doing that. I really celebrate your courage. I know that couldn't have been easy. Thank you for doing it. And you can trust me that except that your life is at risk or somebody else's life is at risk. And we would agree before I will share this. And then we'll then finally agree next steps. What do we do from here? Where do we go? It might be that this conversation, that's it. We don't need to speak again. It might be that we need to touch base, but whichever way, we need to have next steps. And then the values, those are the values that that we all bring into that conversation. Being authentic, attentiveness, reciprocity, parity. I'm not the be all and end all. I'm not the professional who comes in and is wearing a crown and everybody's looking up to. No, I'm actually another person, a human being speaking to another human being and just trying to engage in their distress and helping them out, knowing that none of us are infallible. And that parity is very important, particularly when it's a man talking to another man. That's what I find when I speak to men, particularly middle-aged men. The first thing I do is to take off my mask and say, actually, bro, we're at par. Yeah? There's no, let's forget about all let's forget about anything that makes you feel that we are not at par. It's just one conversation from one human being to the other. And that's what's important to me at this stage. I want us to think very quickly about a time in our lives when we felt that it was okay to be vulnerable. When we felt that it was okay to take off our masks. One of my favorite talks is about how, as middle-aged men, we wear masks. And those masks have almost become a persona. And sometimes when I go to these talks, I'll say, oh, I'm starting, for disclaimer, I'm taking off my own mask now, and I'm encouraging everyone else to take off theirs. So you can see my face. So I hope I can see your face too. And that works. I just want us to think about it. Let's just think about it for a while. What was it about that environment? It could be an online environment, it could be a physical environment. What was it about that situation? It could even have been a meeting that made us feel that actually it's okay to let down my guards here and be my real self and really show my weaknesses and take the risk. What was it? It's always something to think about, because if we're able to think about that, then we can also recreate that. I've got a vulnerability video, but I don't think I'll show that. I think I'll just move on because I'm aware of time. This is really about listening. Developing our listening skills is one of the greatest skills that we can develop in terms of being an everyday jobbing suicide preventer. Learning to listen, not pretending, not selective listening, but really attentive listening in terms of taking away all the distractions, but empathetic listening, entering into that person's life in terms of thinking about what it feels like. It's not just being in touch with the facts, but the emotions as well. What could it be like for this man at this time? And I think this is from the Mental Foundation in Australia. These are part of the things that they say we could be doing to undistracted time, creating a safe space, skilled AI without passing any judgments. Yes, this is from Australia. They say to be calm while we're talking, to be calm and to give that person attention when they're talking about their feelings, to ask open-ended questions, to show that we are listening by summarizing, to clarify the important points. these are the things that I've heard you say. Is that correct? And then express empathy for that person. So these are the questions to ask ourselves. If it's something we can plan for, sometimes we can plan the conversation because we already decided that I'm going to speak to Mr. X today because I've noticed a trend over the last 2 weeks and I'm worried. So am I in a good headspace myself? Am I willing to genuinely listen? Because you know, I can't imagine how many times I've talked to communities and somebody raises their hands and say, you always encourage this vulnerability in your talks. But the reality is I was once vulnerable in a place and it was thrown right back in my face. And I decided to shut up as a result. It was just like, really, I wished that I didn't put myself in that place. So it's also about, am I really genuinely willing to listen? Because sometimes when people then spill their guts, it's obvious that we are shocked and we are not prepared for it. And our responses just makes them go back into their closet. Some of them making vows to themselves never to open up again. And then they then become another challenge for a therapist or a counselor who then meets them 5 years on. That's hopefully that they live through that process. So am I prepared for them to open up? Do I accept that they might not be ready to talk now? It might be tomorrow, it might be next week. Have I chosen somewhere private and comfortable? Have I figured out a good time for them to chat? So obviously it's got to be comfortable for them as well. The environment has got to be right. And a good video, a good source of information and how to look at this is it's an Australian website, Are You Okay? It's a shortened form of Are You Okay? But they've shortened it into ruok.org.au. Very resourceful site full of lots of information. So this slide is really about what we can do as employers. The workplace is where most of us spend the best part of our time, our waking time. And the reality is that improving the climate in the workplace, and I want to ask us a question. Have we ever thought about the climates and the culture in our working environment and how we contribute to that? And if it's a toxic one, is there anything that we are doing to intentionally improve that climate? Because we can. We really can. I was saying this on Thursday that every time a psychiatrist or any professional at all goes to an inquest, a suicide inquest or a death inquest, it's not a nice experience because you've scrutinized yourself over and over and over and over again about what did I miss? What did I do wrong? What could I have done wrong? What phone call did I miss? What if I had given a different medication to that, maybe not, maybe. And I had that opportunity because the learning opportunity on Monday, exactly a week ago, to do that. And the support I received from my team was phenomenal. I mean, there are people who they knew it was an online event. They knew it was literally that they were watching my door. Because as soon as the event was over, there were people who were coming to my office and saying, "Oh, how did it go? We hope it went well." And that support was just nice because obviously it was a difficult experience. Somebody had died, and it's not always nice. As a professional, you would have gone through a lot of introspection. So, and what are we? But we can all create those beautiful supportive atmospheres. And I just want us to think about that for a moment, because that could be something we do to contribute to suicide prevention in our communities. So that's the England Suicide Prevention National Strategy. Basically, the new things are that domestic violence, gambling, online safety, and people on the margins of society, people with disability as well, are now also at risk groups to look out for. And suicide prevention does not happen except it's driven from the top. And the other people who can be involved, education, universities, media, people who are working with children, non-statutory organizations, all of us have a role to play. I think that's just about the fact that suicide prevention in communities, in churches, need to be driven from the top. It's got to be the leadership have got to buy into it. If they don't buy into it, it won't happen. So there's got to be policy backing it up, and that's a good thing, because the people I see in this room are people who can make things happen, who are in a position to make things happen, so we can make it happen. So using national or international mental health awareness days to spread information and to share information is another thing that can be done. And confidentiality is very important. So those are resources that we can look at. The CDC, that's where I got the recent ones from. Samaritans is a very good one. Are you okay? They have mock videos on how to really approach different groups of people on having that conversation. Papyrus is also a very good one regarding youth suicide prevention. Thank you for listening. I think now open to comments, objections, experiences, anecdotes, just anything that.
Thank you so much. Oh my gosh, that was deep in depth. Dr. Lillian Agbeyege, who is in this same field, says thank you. And she had some comments earlier regarding the video you posted. Sister Lola said, and we should engage in social activities, the smile video. And Auntie Tawa says, be your brother's keeper. So, Dr. Lillian, when you first started presenting, talked about the fact that, and you said it later after she, you didn't see what she was writing, that in the US, it's been a long-standing public health approach to suicide prevention to have a team in the US. So I'm glad that the UK is catching up. You're muted.
Yeah, we are. Yes, indeed. We are beginning to look at the collaborative approach that actually it's just more than what mental health or health can do. We need education. We need everyone, but non-statutory organizations, particularly faith organizations, churches. I think these are places where sometimes people listen to their pastors more than they listen to their doctors. It's the reality of life, and we can use that to our advantage. So, interesting.
I agree. Dr. Lillian, can you please unmute? Because I'm trying to make up this, this next one. When you were talking about the statistics with men and women, I think she was saying, women are highly or more suicidal, but the men tend to complete it more. Do you agree with that?
Yes, absolutely. I agree. Okay. Yeah, I agree.
So I have questions. They say that I've heard, and I think I've read, that people who intend to die by suicide, and you corrected us on Thursday that we don't say that somebody committed suicide. And I keep saying it. I need to, to learn that it should be somebody died by suicide. Correct?
Yes, that's correct. Yes. And that's because suicide is not, so in most countries of the world, I think in only about a handful of countries, is suicide still a crime. Suicide is no longer a crime in most countries most advanced nations of the world. So if we say somebody committed a crime or that, then we're already putting them on the back foot, and we're already making them feel, if I'm about to commit a crime, I'm not going to put up my hands to say, I'm about to commit a crime by thinking of suicide. So it's really to decriminalize the theme of suicide and remove the stigma so people can ask for help.
So, you know what? I get it now. Yeah. When we say they commit suicide, it's like committing an offense. It's what
offense,
you say.
Yeah.
There are countries where suicide is an offense.
Yes, in Nigeria. Thank you, Dr. Lillian. Actually, that's true. Yeah. Sadly, in Nigeria. Yeah, it's still, yeah.
Suicide is an offense?
It is a criminal offense, and Nigeria doesn't have a national. We don't have I think they're currently working on it in terms of mental health acts, anything that mirrors the mental health act or mental health regulation in terms of how do we support people with mental problems. I think that's something that's it is.
Well, that's good to know. So it should be somebody dies by suicide.
By suicide, yeah.
Okay.
I'm just going to plug my laptop. I'll do that in a minute. So it's okay.
Okay. So this is a huge learning curve for me. You know, I didn't know that in our own beautiful country, Nigeria, suicide is considered an offense. It is.
I have a question, Dr. O.
Yes, please.
I mean, it's there's nothing amusing about suicide, but isn't it almost lunatic to classify suicide as an offense? Because an offense is punishable by whatever it is. So if somebody commits suicide, it's a self-inflicted injury.
Mm-hmm.
You mean that if they did not die from that suicide, it's still attempted suicide? They're going to be punished? Because I don't understand the classification that it's an offense. It's a sad thing.
It is.
Yeah. So, Dr. Ajayi, kindly respond to that. That is an excellent question.
It is.
I want to understand it.
Yeah, and I couldn't agree more. But I think it's in those days where that started in those days where people thought that criminalizing it was going to deter people from dying by suicide. But progressively, and this was in the Dark Ages, I think it was in the Dark Ages where people did not really understand mental illness as much as we do now. And it's really regrettable that despite the fact that there are so many psychiatrists in diaspora who come out of Nigeria, that Nigeria is still at that is at that place. I know that quite a lot. I know a number of my colleagues who are actively involved in shaping the mental laws and regulations in Nigeria, and I'm hoping that that's going to shift. I've seen, I know colleagues who go over and engage in conferences, and I'm expecting that in the coming years that will change.
I hope it's not in the coming years. Dr. Ajayi, we need to chat because I know you know lots of people. You have lots of colleagues in Nigeria. We need to change this. I mean, it's about education. People should not be punished for a mental health issue. They need help, not punishment. And Sister I know in the chat box says, should we say for us in Nigeria, the semantics of commit suicide is still correct?
Absolutely, yeah, absolutely. You're right. I like that actually, because it's still an offense in that country. So it's still, So whilst in other countries where where it's no longer a criminal offense, it wouldn't be commit suicide. But in Nigeria, that's very poignant actually. Yeah, true.
And so I think that it might have been misunderstood in translation. According to the Bible, it is a sin. Suicide is a sin. And most offenses are considered sin. It's something you did wrong. Somewhere, somehow, I think maybe whoever was translating this into law wrote it as offense instead of a sin. Because it's ludicrous to
Whichever way we look at it, it's ludicrous, like you said.
It is.
Dr. Ajayi, can you please put down the slide so it makes it
okay? Oh, yeah, sorry.
No, don't be sorry, but it helps. I think, I saw the hand raised. Okay. Somebody.
Dr. O.
Yeah, Dr. Lugutera.
Yes,
you have
hi.
Hand raised. Yeah,
yes,
go ahead.
Thank you, Dr. Ajayi, for that presentation. I would like to add a component about families and young children. When I do work with young children, I'm a social worker. When I do work with young children who, under the ages of 10, are experiencing depression, stress, and all of these things, right? which definitely places them at a higher risk for suicide and other mental health disorders. I think sometimes as adults, as guardians and parents, we minimize the impact of the home environment and how that affects our children, especially these days, right? So we find ourselves in situations where when we look back to the home settings for a lot of these children, their parents are either busy or at home there isn't fun at home, it's chores, it's rules, it's regulations. There isn't family time, dinner time, devices downtime, outing time, vacation time, things that bond people together and things that are important, not just for adults, but for children, because they also need to have that base where they feel safe, loved, and respected. I think sometimes when we have this African mindset, we struggle to listen to our children or even to hear what they have to say, to really love them unconditionally, even if we don't understand or agree with whatever it is they're saying or doing. And so when we don't create that safe space at home, so that a child is bouncing around when they go to school, they become easy prey for other things. But when they have a solid base at home, it becomes a protective factor, and it's harder for them to shift around. You know, in my work, I can tell in my work in school settings, I can immediately tell the difference between children that are grounded at home. The parents may not be wealthy, right? And all of that, may not wear fancy clothes, but those children, from their self-esteem and the way they present themselves, they are so sure of who they are. They are so sure that they are loved and cared for, and they believe so much in their parents versus children who may come from wealthy backgrounds, but you can tell that they're just floating through because they're not grounded at home. So as we have these discussions, I believe that it's so important for us to recognize the huge role that the environment plays in the mental wellness of our children. We ought to be able to prepare them, to pre-arm them, to help them to be resilient so that when life happens, because life always happens, when life happens, we would have given them a strong base from which they can pull themselves and be able to engage with the rest of the world. So I think that's also a piece that is missing a lot these days. And that is a huge factor when it comes to young children and the wellness outcomes that we are seeing in them. So I just wanted to add that to your presentation. Thank you.
Thank you so much. I couldn't agree more. Absolutely. Thank you for adding that. Yeah.
Thank you. That devices thing jumped at me. And, you know, I have hands raised, but I just wanted to mention that Andy Towers said, yes, suicide is an offense in Nigeria, but it is probably something we inherited from the British legal system and we never changed after independence. Do you think so? I'm glad you're in Britain. Is that true?
Yes, because I think it was in 1963 that it was decriminalized in the UK. But so yeah, we that's why I said it started in the dark ages, but then we just continued with it.
Kept it.
Yeah.
Okay. Thank you, Auntie Sawa, for that, because that's it. We need to change too. We have so many educated people now that we need to change. Sister Lola, go ahead. You have your hand raised, and then Dr. Lillian Agbeyege will come on. Sister Lola,
yes. Go ahead. Yeah, I stand to be corrected, but I understand also if you commit suicide, you're not going to heaven, you're going to hell. Because if I have to put it, the Bible says, thou shalt not kill. So I can understand where it's being criminalized.
So are you saying that it is right to criminalize suicide? Is that what you're saying?
No, I'm not supporting that, but I'm suggesting, or I'm thinking that might be where those are coming from too.
Okay. Dr. Ajayi, the floor is yours.
So thank you, Ma, for that thought. And it's quite an interesting one, and it's one that's been debated, and it's a very topical one in Christian communities. But I, as a psychiatrist and somebody who also feels blessed to have a pulpit ministry and to be a pastor, I have a different view, a slightly different view. And that's got to do with the way I say it is, if somebody dies from cancer, we probably wouldn't say that it's a sin and they're going to hell because they got cancer or they had a stroke or they had a heart attack and they died. In the same way, people who die by suicide, a lot of them have a mental illness. At the point where somebody decides to take their lives, it's looking at it naturally is the most unnatural thing to do. Our brains and our entire being have been wired to survive from even before we were born. That's the way we were wired to live. That's the natural inclination. So when we see something that is going contrary to that completely, many times it's because people are dealing with something that is stronger than them. The decision about who goes to hell and who goes to heaven, many times as Christians, we grapple with them. But I also do feel that it's so difficult. I think who knows what happened at the final stage? Who knows? It's also it's a very. I feel that it's quite a woolly area in terms of being able to say categorically that this is what we know happens. And usually when people cite scriptures, I will usually then go, I mean, let's think about the thief on the cross with Jesus. Everybody would have written him up. I'm sure his friends, when they saw him hanging on that tree, they would have thought, oh, he's a gunner, straight to hell. He wouldn't pass go. It's just going straight. Expressway, motorway traffic. However, that last minute conversation was a total game changer for him. And we all know where it ended because Jesus said it. So when it comes to that, I'm not always very, I avoid being very categorical to say that that's the case because I feel that when it comes to when the chips are down, that's God's decision. And many times there are so many things that come into play, and mercy is what we know God to. We know him to be a God of mercy.
Thank you so much. And you know what, Sister Lola, I want to add to what Dr. Ajayi said, that who knows what happened at that very last moment before that life is gone? Only God. We don't.
And the Bible says the secret things belongs to God.
Exactly.
It's a very thin area so that we don't become judgmental about it. I mean, this session is a lot going to mental health. If they don't have adequate and timely intervention, then it goes to the extreme end. So we just need to learn how to do to support. Like the other lady was telling us about children. You know, we all have permanent digital babysitter now. And she's telling us now that, hey, that is not acceptable. You go to church, you see all of these kids, they're all on what is it called? This machine.
iPad.
Because it's convenient for us. Yes. Yeah. Because it's convenient for parents and it keeps them engaged. But we don't understand the ramification of those down the road. You know, their social intelligence is -0 because they don't know how to deal with people. They can only deal with machine. May the Lord help us. Thank you, Doctor.
Amen. Amen. Thank you. Dr. Lillian, kindly unmute. Thank you.
Hello, good evening. Thank you very much. Yes. Doctors, thank you very much for your presentation. A couple of things. Public health in the US advocates a social ecological model intervention to suicide prevention, and that's the recognition that all the responsibility can be on the person. And so everything that people have said sort of ties in, and that's why I talked about social emotional learning in school. When you help people know how to deal with pressures in school, we talk about family interactions that people have talked about. But the important factor is how society responds to it. Because even when you're giving all that love to your child at home and something goes wrong and happens in school or somewhere else, if they do not have the coping skills to deal with it, then where do they go to? If we still have stigma around mental health issues, then how do people reach out for help? Recently, the United States, we changed the emergency number to 988. That's the suicide prevention number, because somebody having a mental health crisis, and people call law enforcement. Law enforcement are not trained to handle mental health crises. They end up killing people who are having a mental health crisis because they don't know how to deal with it. So it's a lot of work to do at multiple levels response, even this conversation about whether somebody is going to hell. So when we look at the social ecological model, this training, for instance, that we're having, how many people here belong in faith communities? How many of your faith communities have had a presentation on mental health? Like Doctor was saying earlier, people listen to their pastors. So maybe your pastor is not skilled, but can your pastor bring somebody who's skilled to do the presentation at some health event that you're having in your faith community, and so that they can really understand what is mental health issue and how can it be disabused and how do people seek for help? The same way people say maybe somebody is going to hell, that's the same way some people think is somebody put a spell on somebody and do not know that they can respond. Sometimes there are people who think, oh, you're trying to say I should go on medication, not knowing not everybody goes on medication, or not knowing that going on medication is not the end of your life. It doesn't mean that you can't live a quality life. So there's so many factors to mental health, suicide prevention, and we all can do this work. Like you said, share appropriate information on our social media and get our faith communities, our tribal communities to host presentations where they can learn more and ask questions. Thank you.
Thank you so much for that. I couldn't agree more. I'm a very aggressive in a positive way, crusader in terms of engaging faith communities. Any church that offers me an opportunity, I'm coming. So yeah, thank you very much for that. That's really profound in terms of really taking the message where it matters and also using the people that are influencers to spread that message, and particularly also, I mean, in all humility, letting our church leaders know that they're anointed to do what they do, but it's also important to recognize their limits and to recognize their limitations.
Thank you. Thank you so much. And thank you. You're right, because you're always there. Thank you. Always there to present, always there to help us. Thank you. Sister Aina Ayodele, kindly unmute. Thank you.
This is Dr. Aina. He's a male.
Dr. Aina, I'm so sorry. Yes. Please, write properly. Put the doctor in front of it so that I can be appropriate next time, please.
Yeah, thank you.
A friend from Nigeria.
Thank you, Doctor. I'm from Nigeria. I'm talking from Nigeria.
Wow. Thank you. Thank you, sir. Welcome.
Presentation. My dear sister Lola, thank you for inviting me to this very educative and informative lecture. I thank God that I'm here. If we look at what is happening in Nigeria today, suicide is becoming quite alive. A few days ago, there was one video clip that was going around on the social media of an aged man who jumped into Third Mainland Bridge or something like that. Everybody were persuading him, but at the end of the day, they could not. And you realize that Nigeria is such a religious country. And it is, I've had a case of somebody coming directly from the church and then went to his house and, well, I can say commit suicide now because I'm in Nigeria. So I think so much is needed to be done. Churches, religious houses are not really helping matters because their focus is more on some other things. And maybe really, the education is not there, even for for the pastors, for the imams, or the awareness that people, from the lecture, we realize that truly poverty is part of it. There was a woman in Abeokuta, sometimes July, who, because she borrowed money from one of these, this Lapo, whatever, and then could not pay it, 70,000 naira, and went straight to filling station, bought a 5-liter petrol, went into her room, poured it upon herself, and burnt herself, just for 70,000 naira. And you could ask the question, is either a Muslim or a Christian? And so you realize that some of those things, that we say in the church may not even work. Because when the matter comes up, it is what is pressing them. It's not what you want to tell them, please wait till tomorrow, unless you can help him or her directly to come out of the problem that is staring him or her at face. So much work is needed to be done in Nigeria. At my own private something, I tried as much as possible to talk to people who comes to me or I know about, but generally, I think even the government of Nigeria is not being aware that suicide is on the increase all over. And how I wish things like this could be done frequently in Nigeria and not, we don't even have statistics. I don't think we have statistics. Because if we have statistics, it will have even geared up even our health professionals to look into all these things. So I don't know what kind of advice, can be given to us, like a call to come and help us in Nigeria. I don't know. Thank you very much for the evening. God bless.
Dr. Ajayi, thank you so much. Dr. Ayodele, God bless you, sir. Dr. Ajayi, go ahead.
Thank you so much.
Ajayi. We have a solution, Dr. Aina. We need fundraiser for NTA. We're bringing Dr. O to Nigeria.
That's good. That's very good.
Yeah, we put it on NTA. Yeah, Dr. O will have a talk show on this once a week. But we need money. We need funding. So let's rally around all the big people there in Nigeria. Let's help us to work on that. We're ready.
Thank you.
That's a solution. That's one. Dr. Ajayi, she's right. We need to create awareness. Dr. Ajayi, go ahead, please. I want you to respond to him. This is a serious issue.
Yes.
Not criminalizing suicide, desensitizing our people regarding mental health.
A bill will have to be
passed.
To be dumped on that, to send to the House of Assembly, or to the National Assembly, and to even let them know, to let them be aware that Nigeria should no longer be tied to the apron of UK. We should have our own laws. We should have our own things, not the old mentality of colonialism. Mm-hmm. So I thank you very much, Doctor, for saying you will come to Nigeria. I beg, come to Nigeria and help us.
Madam CEO said, so it is done. No, I'm not kidding. We don't kid. We don't joke. It's a serious matter. We don't. Dr. Ajayi, I want you to come in because you are coming too. It's not you in this. Go ahead.
Okay. So, it's a valid point you've raised, sir, in terms of the issues. as you were talking, I was just thinking about the fact that we don't even have data. There's not a lot we can do when we don't even know the state of the nation in terms of suicide figures. We don't have any way of knowing that what's the high risk, what's the age group where suicide is the highest, who are the at risk people. We don't have any of those. So that's where things will start from. But the also encouraging thing is that when I look at the other nations of the world where progress has been made, it's always been one effort at a time. And that's why the fact that, as has been said, that Dr. O is coming to Nigeria, I think that's a great thing, because I think it's a step in the right direction. And being on national TV is a powerful thing, because the impact, the reach, and those are important things. So I think it's a message of hope I really want to give, that it's possible to change that narrative. And we don't need the juggernauts and the politicians. We don't need all the juggernauts and the politicians on our side. We just need a very determined cohort of people who are resilient and who keep knocking and who keep taking the message. Just as a case in point, recently, only on Friday night, I was listening to I was privileged to be at an event that the Royal College of Psychiatrists president was at. Actually, she's a Nigerian lady. She's actually a Yoruba lady. And she was saying that actually that everywhere we go, that the message of mental health is one that we should be propagating everywhere. That everywhere we go, whether we're with politicians, wherever we go, and that we should really put that message out there. And also to say the things that these things can work. We can make a change. We can determine outcomes. We can help national productivity. So I think the places to start would be, one, to engage all the stakeholders, that includes the politicians. And also, I think there's a lot of support that can be harnessed from the professionals in diaspora. Lots of people, I mean, the leaders of mental health in the UK, for instance, quite a lot of us are Nigerians. So, and I'm sure it's the same in America as well. But I think the conclusion for me is that it can happen, and it will happen. And even the court here can make it happen. So thank you very much, sir.
Yeah, I concur. Madam CEO, you can unmute, ma'am. You're still muted. You're muted.
Yeah. Yes. Yeah. Thank you, Dr. Ajayi. You know, this thing is it's not a cliche. This is real. And when I'm proposing that we bring Dr. O to Nigeria, I was not saying it in a facetious way. I mean it. So we have the psychiatric organization or whatever it is. You guys need to come up with some kind of fundraising, because going to NTA takes money. Okay? It's going to take money, but we need to start the awareness from there. We need to start a no denial, no demonization awareness, because that's what's going on. So please, after this, let's work on it. Thank you.
We will. We'll call the meetings. Thank you, ma'am. Dr. Ayodele, sir, you can unmute. Kindly unmute, sir.
Oh, sorry.
Yeah.
I just want to say thank you very much once again. Like you have already said, we really need our people in the diaspora to help us lead this thing, connect with those in Nigeria, our doctor, the psychiatrists, and everybody that you
once
know.
Again. Like you have already said, we really need our people in the diaspora.
Hello. I don't know what is happening here.
I'm sorry, sir.
I'm hearing myself again.
No, not you. Sorry about that.
Okay.
Somebody was.
Thank you.
Yeah, sorry.
Thank you very much. All right. So like I was saying, we need to, the promulgation of the bill to the House also, Senate, House of Representatives at the national level, to first of all, take away the obnoxious belief of it's a criminal thing, because nobody will just wake up in a day and say, let me go and commit suicide if there is nothing behind it. And if you look at it, majority, it was not as much in African setting, especially in Nigeria, especially in Yoruba land. They love enjoyment, they love, so they can't just wake up. If it has not been the activities and the action and inaction at the leadership level that has percolated down to, to the masses. So I think those are the areas that I'm thinking about. Promulgation of a bill to the House to remove the obnoxious belief that suicide is an offense.
Okay, Dr. Ayodele,
Yes,
kindly share your contact with me in the, if you please direct message me to share your contact, and we will discuss this further.
Thank you very much.
Promise.
Wonderful. Thank you.
Yes, sir. So, I'm sorry, it was Mr. Doherty from California, Maegon, who said, we got this from the British, and he went ahead to say also that he found out himself that a young man tried to jump from Falmouth Bridge a week ago. He did jump. He was eventually saved. They saved him. So I don't know if he was then punished after that or what came of it. Mr. Doherty, if you please help us know that would be great. Sister Tinuade said to educate the leadership, lawyers, judges, community, and all stakeholders. Let mental health officials, psychologists, and psychiatrists engage the populations. And Dr. Ayodele, you already answered. Dr. Ajayi, you already answered. My sister Lami Dongoyaro, please kindly unmute to ask your question. Go ahead and unmute. You're still muted.
Yeah.
There you go. Welcome.
Thank you everyone for this beautiful, beautiful session on mental health. Well, basically, I did agree with Sister Lara about suggesting that, you guys take the campaign to the NTA and all that to create awareness. All well and dandy. Prior to doing that, I think there's the need for you to do your underground work, to talk to the legislatures and the Senate, to have them hear you guys out. Then maybe they might have some input, or maybe they could grant, the group, going an audience to even speak to them. But just going straight to NTA, I happened to work for NTA before, or NTA Nigeria, it's not going to cut anything, as such. People will be transmitted. You pay your money, they transmit it. But go to the root, to the grassroots, to the legislatures. They have the power to change the laws. For instance, the law that we had from Britain before, they have since changed theirs. So let us educate them that needs to be changed. Thank you.
Thank you so much. I think Madam CEO was talking about educating the public. But in terms of legislation, it has to come from, you're right.
They have to do that.
And, that's what Dr. Ayodele was saying, that we need to start from there, to do that, to change that law, to decriminalize it. And you're right. Thank you. So we'll be talking to you too, because you have those contacts. You have to be on the team. we have to make changes. This is bad. We're talking about suicide in Nigeria. The same thing is going on here amongst our people. I've never seen it like it is now. We need to move. We need to do something. We are a village. Thank you, sis. Dr. Bukka, kindly unmute.
Yes, thank you very much. It was very interesting. You know, I dislike psychiatry, but now I'm really interested. I always ran away from the classes. But please, we need to educate the doctors. I have known a few physicians who have committed suicide, especially anesthesiologists. So it's not just the lay people or whatever, it's also the professionals. And maybe we should send something to the new Minister of Health, or Federal Commissioner, Pate. And one guy from my college, Aluso, just went over. Maybe we need to start with the ministry and then move on, because a lot of doctors need help too. Thank you.
Thank you, Dr. Bukka. Right on point again. Oh my gosh, my sisters are hot. So are my brothers, you know. We know that the profession that commits suicide the most is physicians. And on top of the list of physicians who die of suicide, I've got to learn to rephrase that. Psychiatrists, anesthesiologists, and community doctors. So you're right on the money. We have to address that. Thank you. Dr. Veronica, my darling sis, kindly unmute. Dr. V.
It was not letting me unmute. I'm like, okay. Hi, Dr. O. Thank you again for a very relevant topic. Sorry. I wanted to bring in the perspective of schools. As Madam Theo has brought this very awesome idea for us to actually engage Nigeria through the media, which once you start NTA, then it will definitely go viral on social media, I'm hoping, because this is to reach our people. I don't know what got in my throat. But I'm thinking of schools, because here, I've been in the school system, when you're talking about mental health, we have to go to the grassroots. So let's be intentional about including schools, because that's where it begins, where children are beat up, tied up, described as irrelevant in different ways. Because we don't have, I don't know, I shouldn't say we don't have, I don't know what kind of system we have in schools to identify mental health issues and to somehow in all these phases bring the medical perspective, but also bring the educational perspective of socio-emotional and identification of mental health, a mental health intervention, which is kind of what you do for the adults, but you studied in the grassroots with children. So I just wanted to bring that up. Thank you, Dr. O, Dr. Ajayi, and everybody. It's just really, really, really hot. Yeah, thank you.
Thank you so much. What you're saying is we go to the grassroots. We go to where it begins. A lot of bullying in the schools. Thank you. That brings you into the equation. It's going to take a village. This is huge because that's your territory, education, and it's going to take you involved. You see, it's all of us together. This is not just psychiatrists. This is not just doctors. Dr. Bukka had rightly said, doctors too are the worst in this danger. I mean, and God will not make any of us endangered species. So we have to come together. Put you on the table, Dr. V, for us to do this together. But we can do this.
Yeah.
Because at home, we're gonna look at in here too. We have a lot of issues here.
Thank you, Dr. O. Thank you.
I think Dr. Ajayi has been answering the questions in the chat box. He has helped a lot. But some of the comments there is that churches, mosques, shrines, synagogues, and worship centers, tithes and offerings So I guess Sister Tinade was saying that, churches are interested just in the tithes and offerings and not in the mental health. So we need to change that narrative too. And Sister Clementina says also Nigerian social system is minimal or close to non-existent. There's also negative social and environmental factors that heightens suicide. But Dr. Lillian said there's already advocacy work on this in Nigeria. So we need to know about that. If there's something going on already, that's what we need to build on and not reinvent the wheel. So I will dialogue with Dr. Lillian to find out what's on ground, and then we can build on that. I guess, even Dr. Ayodele may not know that, which, it can be part of. Oh, I see something here on, a link that maybe take us to where that is. So exactly, Statunade says collaboration is required. There are organizations who, I don't know what this is, whose prime focus is suicide prevention. All we need to do is partner with them and utilize the influence we have with the elite class.
Primary,
whose primary focus is suicide prevention. Thank you so much. So we're going to chat and see. It's better to build on what is existing. Yes. So, I've said it. I have an information that I'm not, it's not necessary to share, but we already have contacts. We already have contacts. Dr. Ajayi too. I keep saying Dr. Ajayi has many friends. I've been on his programs, sometimes quietly. Again, it's every last Thursday of the month, once a month, and it's all mental health. Phenomenal. And I know that he has lots of friends in there. So Olatomi says, nobody watches NTA. Please use channels TVC, AIT, etc., but not NTA. Mr. Duarte said it doesn't know what happened. It does not know what happened to him, the guy who jumped and was saved. But that was when the discussion on Arise News came that it was actually an offense in Nigeria to commit suicide. So Sister Tinade is calling for sensitivity meeting, and I think, Mr. Duarte also wrote that the late Dr. Adeoye Lambo used to be an advocate for mental health and ran Arrow Mental Hospital for a long time. And Dr. Ajayi is recommending a good book to read. Prof. Claire Gerarda's book, Benita, the White Coat, Doctors, Their Mental Health and Distress. I'm sure every doctor on this platform would be interested in reading that. I'm going to get that because we need to read it.
Yeah, Dr. O, I have my hand raised.
Just 1 second, ma. I'm going to call you in 1 second. Mr. Duarte said he wonders why anesthesiology commits suicide more than other doctors. We're going to have Dr. Buka answer that. Oh, Dr. Ajayi. Oh, Dr. Ajayi answered. Easy access to lethal means. They have the medication. They have what they need. And Ivy in London, that's my sister, says she thinks we should consider TVC as it is the president's TV station and better watched. So TVC are not NTA. So go ahead, ma.
Yeah, in terms of the media station, all of them are relevant. It's a question of funding. If we have money, we can do it. But because of the stigmatization, I think that in a subliminal way, we should also address companies, particularly tech companies in Nigeria, to have this as part of their wellness program for their staff. instead of just saying, oh, somebody got fired because they can't keep a job or whatever. There's so much going on, and there's so many ways to provide intervention. You know, in America here, people allow their staff to go for, what do they call them? Counseling. I don't think that is available in Nigeria, but that's something that needs to be introduced. It's about strengthening the mental health of our community. It's not about demonizing anybody, which is probably why some people will not come forward to say they're going through stuff. So it's not just the schools, the big companies that can afford, at least they need to incorporate. This is probably where the legislation will play a role, that companies should incorporate counseling into their, whether it's marital counseling, whatever it is, into the benefits that they offer their staff. Thank you.
Thank you, ma'am. There is counseling in Nigeria because I have navigated some for some people who needed it. So we need more, I'm sure, but we do have counselors. How they utilized without one having those personal, contacts, I'm not too sure. Those are the things we need to look at. Dr. Bukka.
Yeah, can I say something? I think this has been so interesting. But thanks, Dr. Ajayi. Can you, when you're going to Nigeria to liaison, maybe you could also get the psychiatrists in England too with a joint, you could do a joint movement to Nigeria. But, there's something somebody said to me, and we have to be careful about kids, the way we raise them. And the churches play a part. For instance, when we were growing up, they would say to us, oh, if you do that, gentle, Jesus wouldn't like you. Now, if you tell that to a child now, it takes on a different connotation. And we have a way in Nigeria, say, oh, God punish you. Some things we just have to stop saying because the younger people may take it literally. For us, it was not. So I think we all have to change our comments and way of life or know who to say it to. I don't know if anybody disagrees with me.
Oh, we agree. Especially to the young ones, what you say have a long ways to go. We have to be careful at what we say. We have to affirm them. We have to be positive, always. Even, for instance, weight. You say a child, has weight. We have changed that, narrative in primary care. We don't say children are obese. We say they are. There's another diagnosis, ICD-10 code diagnosis that just says that they are overweight, but not obese. The word obese is not used in pediatrics anymore. Things like that, can, really affect children. So thank you. Thank you for that. So Dr. Ajayi, you said large frame is what you use. What does that mean? But please elaborate on that. And Dr. Lillian, gave us a lot of information. I think she's speaking on Thursday also to some group, but we don't have the link here. So Dr. Ajayi, I'm handing over to you. I've gone through the chat box because I know you're in London and time is running. I'm looking at the time.
Yeah, thank you, Dr. again. The large frame was about when you were saying in terms of semantics and words to use in describing people overweight and obese. So these days, and that's because from experiences, people not wanting to be described that way and how pejorative those terms could be. So sometimes it's more acceptable when somebody says that somebody's of a large frame. That we are not actually saying they're obese, they're overweight, but we know what is being referred to, but at least it's not being stigmatizing or it's not derogatory either. That was why I said the large frame.
The large frame. Thank you. I have a question for you, and I'm so glad that, I think I have a little bit of window to ask it. It is said that most people who commit suicide will tell at least one person, sometimes up to 3 people. Is that correct? And that people they tell don't know what to do or they don't believe them until after it's done. Then they'll say, oh, they said it.
Yeah, I think it's very rarely the case that when after people think back on a suicide, that there's no one person that will say that in retrospect that there were warning signs. They may not have been verbatim, they may not have been very clear, but more likely than not, those people would have been leaving signs. They would have been dropping hints, whether consciously or subconsciously, inadvertently. Most times when people look back, they could actually say, yeah, we did 2 weeks ago, they said something. It could be even two parents on the playground. It could be just a passing comment. Like I said about the passing comment about somebody who said, oh, they just say, oh, can you please tell me how to find a counselor? That was what I had, but it just didn't sit well. Tell me how to find a counselor created too much turmoil in my heart for me to feel that. It just felt more. It was and the way it was said, within a few minutes, it was just like that, and the person was gone. So it's true that suicide actually leaves hints, and that's why it's important for us to be more alert, and to follow our gut instincts. It's better to be wrong by following the wrong lead than to miss the right lead. If you see, I'm not sure whether I put that right, but it's better to go on the wild goose chase and find out actually there was nothing wrong. I was just being overcautious, than to find out in retrospect that actually I might have intervened and saved somebody's life from dying by suicide.
Thank you. So when we see somebody that, is really vocal, talking and all of that, and then all of a sudden you call them, they're like, yes, no. Then we need to do something. We need to not just end the phone call and go to the person. What's going on? Because I've seen that happen and the person committed suicide. But the person they were talking to knew that something was wrong. They were not responding the way they normally, chippy responding. So thank you so much. When you said that, it jolted my memory that, yeah, maybe not saying it, but they will show something. There will be telltale signs. Or, you went over the depression symptoms. They will maybe show some of those. Thank you. Dr. Ezugwu, you have your hand raised. Kindly unmute. Thank you.
Yeah. Thank you, guys. Sorry. I haven't been able to.
Oh, you left the office already?
I left the office already, yes.
Thank
you,
God.
Dr. Ajayi, for really a very stimulating discussion. And thanks to everybody who actually talked about call to action. I have two questions. One is, does the Nigerian National Health Insurance, does it cover psychiatry issues? If somebody can answer that from the Nigerian.
Dr. Ayodele, kindly respond to that question. Dr. Ayodele, are you still there?
Yes, thank you.
So, did you hear the question, sir?
Yes, I heard.
Thank you.
Because of not really. Our health insurance is actually very epileptic, it has not really found its footing since the time, it started, except for some companies, but in a jiffy, it doesn't.
Yeah. The reason why I bring that up is that, having been working with some of these national health insurance things, you have to bring certain things up to them to really push for coverage for that. And if we're gonna be, coming to call for action in that area of psychiatry issues, we have to then approach it that way and educate them from national health insurance for coverage for those type of situations. Because for those areas where it's covered, they do very well. For the healthcare conditions where they cover, they do very well for patients. So that would be something we can come around and try to work with them to at least extend coverage in those areas if we can educate them to do that. That would be what I would suggest. Yeah.
Wow. You know what? I'm writing down action plan. Dr. Ezugwu, you're in. That is it. And Dr. Ajayi, Dr. Ezugwu, started the, cardiology, state-of-the-art cardiology clinic in Enugu. And I twisted his hand to start one in Lagos.
Yeah, we thank God. Yes.
So there's one that has opened in Lagos, and they, take the healthcare plan. So for families that we have in Nigeria, I'm glad it came on and talked about this. For $50 a year, you'll cover your family member. And they provide primary care and anything to do with the cardiac health, which is, it's robust. So that's why he's asking if this covers mental health. He fought for them to cover cardiac health. It used to be just primary care. He was one of those who pushed for the government to add cardiac health. And so it is now covered. So it's going on an action plan to do that. And he's done it before, so we're going to do this again.
Yeah, it'll be good to really push and see, because again, education is the key here for, the national health, and really getting people to understand what can make them, hold them accountable for more coverage for certain conditions, and companies can cover that for people that work for them, and again, even those insurance, you can buy them for much lower than $50, but sometimes the co-pay and other 10% they have to pay prevents them from getting other care. So when you extend it to $50, then they're able to get those or that additional care without having to come up with any money from their pocket.
So that's why I rounded it up to $50 because it covers the co-pay. So everybody on the platform, you have family in Nigeria, please cover them. Hit me up, I'll contact you, I'll send you the contact of the office in Lagos or Dr. Izugu's contact, either one. And they can go there anytime. And they're covered with no copay or anything. And we will get the mental health thing. I mean, we have work to do now, a lot of work to do. So
my second question, sorry.
Go ahead.
My second question is more for my own education. In the area of criminalization of suicide, what was the suicide rate before that criminalization? In areas where it was criminalized and in areas where it's not criminalized, what is the rate in those countries? Right? If in a country that had it before and later on lifted the criminalization of it, what was the change in the suicide rate after that lifting of the criminalization of that act? If anybody knows.
Like Britain, right? Dr. Ajayi is the only one that will know. I'm kidding. Dr. Ajayi.
So I don't have those figures specifically about pre and post decriminalization, but what I do know is that the criminalization of suicide was something that was done years ago to try to control, to dissuade people from dying by taking their lives. However, it became apparent that was not working. It was actually festering the suicide because it was becoming something that was secretive, something that people could not own up to. And rather than seeking help, they still continue to take their life. But what we do know is that from the figures, we do know, for instance, that since 20 years ago, since this would have been very early in the noughties, when the UK started the National Suicide Prevention Strategies, that there's been a 20% drop in suicide rates relative to pre-strategy. But I think it makes it sounds rational to say that when an act has been criminalized, it festers secrecy, it festers suspicion, and it means that it hinders people from seeking help because they will feel that their help seeking could then result in reprimanding.
Thank you. Appreciate that. Yeah.
I think she might be frozen. You need to unmute, Dr. Ho. You need to unmute your phone. We can't hear you.
Oh, I'm sorry. I was talking. Oh, I'm sorry, Dr. Ezugwu. I was addressing you. I'm sorry. I didn't realize I was the one muted. I said people are asking for how to get the insurance in Nigeria. Whose information would you like me to give?
Oh, sorry. Yeah, we can put the HDPD. You can also put my contact on the listing on the forum. So that's fine. Yeah, and they can always reach us through you. Any one of those. Yeah, that's perfect.
Yeah, I'm on the board, so sure. I just don't like saying it. I want Dr. Ezugwu to take all the credit.
No, credit for all of us. It's for our people. Our people need our help from anywhere, any place. So we are all in there to fill that gap. Yes.
Yes. So I'm going to put Dr. Ezugwu's information there for those who have asked for that information. It is very important. They will stop bothering you that they have something, they have any health issue, they know where to go. Because the insurance is already paid for the year for $50. That's right. I mean, we have tons of people that have done that. It gives peace of mind. And it helps our families also stay healthy. It's part of the advocacy. And it's excellent health they get. There's also, a virtual treatment from the US. In conjunction with excellent physicians in Nigeria. The physicians that are handpicked to be there are stellar. But, virtual intervention from the US is available all the time. Am I correct?
You're absolutely right, because we use electronic health record and we have direct connection with them, and they can reach us for any questions or any care. Yep. Yes.
We need to add the mental health added. Yes. So, Dr. Ajayi, please, do you want to handle the chat box? Because you already answered, to see which ones you have not answered or that you have answered you want to talk about. I don't want to repeat and be repetitive.
Right. Some of them are comments. Some of them have responded to. Okay, that's the one on the health insurance that's been responded to. Okay. Education, training, dissemination of information and advocacy, and then signposting is the way to go. I absolutely agree with that. Those are really key strategies, and the collaboration as well. We miss those hints because we tend to think suicide only happens to those people. A person has to be employed without a spouse, boy, etc. I think I've also responded to that. That's a valid point, Dr. Lillian. Being alert to symptoms in those not conventionally deemed as at-risk group is important. So it's really, rather than categorize people as high risk and low risk, I think it's just better to follow our gut feelings, particularly when we feel that there's something not quite right, to explore those and not feel bashful. Because when we think about the impact that we might actually be saving a life. Yeah, coverage for mental health is inadequate even here in the US. It's a subject of much advocacy here. Mental health services are grossly underfunded, absolutely. I couldn't agree more. And that's why I think community psychiatry is the way to go, where we are all equipped with basic information and knowledge to be able to spot, at least to be able to raise concerns and to signpost and support. Because indeed, I don't know of any nation of the world, if you the medical community in America are saying that you're underfunded, that is as good as it gets. I suppose the only places probably where those figures are better will probably be in places like Dubai and United Arab Emirates and those type of places. It's a taboo in Africa, in African culture, to commit suicide, especially the Yoruba culture. It's as bad as the family fails to disclose the cause of death. That's true. When I was growing up, I remember that they used to say, I don't know whether it's still the case now, but that when people die by suicide in the family, it puts a stigma in that family. And in those days, in fact, when investigations were being done by families, if somebody brings home a spouse, a lady brings home a man, or a man brings home a lady, one of the things that the person's family will do is to investigate that other family's history, and that includes whether there's mental illness or suicide. But those are things that really we need to, that's the things we need to be speaking against in the places that matter, and to try and change that narrative, that those stigmas need to go, because there are hindrances to people seeking help and getting help. Right, I agree with that we should change the policy. Yeah, thank you, Dr. Agbe for that, Dr. Lillian, for sharing that information about President Buhari signing the Mental Health Act. Yes, that's good that the human rights of people with mental health problems is being protected. I suppose the next stage would then be to have laws in place to actually protect them against themselves when they are not when they lose capacity and they're not in a position to help themselves. That's still a key issue in terms of when somebody loses capacity to be able to make decisions regarding their own mental health and their own mental well-being. What systems are in place to get them treatment against their will, which is something that needs to happen in the territory that we deal with in the domain of mental health problems. I think I've answered it for the one on why anesthetists are at high risk. People say that people who die by suicide is an act of cowardice and selfishness. I think it's actually brave.
Yes.
I think it's actually a brave thing for somebody to get to the point in which they call the shots and say they've had enough of life. It's a big step. It's a huge step because like I said, our brains are wired automatically to survive. That's our default wiring. So when somebody crosses that line and they decide, because it's a long road from being well to taking one's life, it's a huge thing to say that one is crossing that line and not just planning it, but executing it so well that it's successfully executed. So, and the selfishness part of it is, I don't agree with it. And the reason I don't agree with it is because I think that if somebody who has cancer begins to lose weight, we wouldn't say they're selfish or they want to get their family into trouble. They want people to think that their parents are not feeding them well. But when it comes to somebody who becomes suicidal or they take their life, people think they are being selfish. So at that point, by the time somebody takes their life, they are no longer rational in most cases. That the ability to be able to rationalize and weigh the pros and cons and arrive at a decision has been altered. And many times they really are convinced that the best thing to do in that situation is to take their lives. There are, in fact, a lot of people who have attempted serious, who have had near-death experiences from attempting suicide will tell you that actually they were convinced that they were doing their community, their parents, their family, their spouses good by doing that. That it was like ending their own misery so that the misery of other people could end. So at that point, it's not that they're even being selfish. It's actually that they are thinking, they don't want to be burdens on other people again. So they better they see themselves as a trouble. And so they say, okay, rather than continue to be trouble to everyone, let them go out of the equation. That's usually what the experience. That's usually what we hear from people who have come back who have had an unsuccessful attempt. Yeah, it's medical assistance to suicide. Yeah, I know in some places, in some northern European countries, it's acceptable where they even have clinics. I forget the name of the most popular one. It ends with a VAS.
It's legal in like 2 states in the US.
Yeah. Oh, wow, okay.
Yeah. I think 2 states in the US, it's legal to have medical assistance suicide.
Yeah, I really do think it's a very slippery slope. It's really a very, very slippery slope. And I'm glad that I don't have to grapple with that in my practice. I've always believed that when I took the Hippocratic Oath as a doctor, it was to preserve life and to do everything within my power to do that. And I wouldn't want to be in a position where I will need to consider that, to consider doing the opposite.
I agree. Me too. I'm glad that it's not legal in our state, so we don't have to worry about it.
Yeah.
And even then, I think every doctor will be allowed to make a decision.
Yeah, absolutely. Yeah.
Yeah.
Like if someone needs to see a psychiatrist or therapist, who can one contact here? Right. Okay. I'm not sure where that's, because it will depend on which country. So I do know, for instance, in the UK, it should be the first port of call would usually be the general practitioner. I know in the United States it would be the family physician as well. I'm not sure where the question is from. I think for Nigeria, it's probably going to be just a direct referral to any of the psychiatric hospitals. But if that question, okay, Nigeria, Ibadan, Lagos, okay.
Arrow is in Abeokuta.
Yes, Arrow is in Abeokuta, and that's I do have a few psychiatric colleagues in Nigeria, so that's something I could take forward. I could make a few contacts.
Can you private chat me so I can have your contact? Yes, absolutely. And Dr. Ajayi finds that information, we will let you know. Mr. Doherty has a question for you.
Right. Can medical assistance should I be submission of mercy in cases of terminal illness where they are suffering? I mean, I think there's a natural cost to life. Thankfully, palliative care currently is at a level where a lot can be done to support people, and many times when people are at that stage where prognosis is very bleak, our palliative care physicians will usually not spare any expense to keep them comfortable. And really, in the real sense of it, most of those, it will be such that the pain that people talk about, a lot of times, palliative physicians will take care of that to make sure that people are not in pain. So the use of assisted suicide for people who are terminally ill, I think it's a landmine, because there's also what did the family want? What would the person have wanted? Because there's somebody who is the primary person in this case. And at that point, they might not actually be in a position any longer to express their wishes. And the other question to ask is, actually, the wish that they are expressing, is it just because of what's happening to them at that spur of the moment? Or would it have been their wishes if there was nothing happening, if they had a choice, if they had a free will to make those decisions? So it's quite a complex one, and I don't think there are any easy answers. But when it comes to it, I think it's about following one's ethics and one's values, which is shaped by several experiences. And for me, I really do feel that I'm glad that I don't have to feel compelled to be part of that process.
Fantastic. I don't know if they start it in the UK, they're going to ask you to do psych evaluation. You know
yes, absolutely. Yeah.
You know how it goes. They're going to bring in the psych team and all of that. But, you know, it's a difficult one. It's a thread for some of us. For me, it's difficult. Thank you so very much. It's late, much later over there than here. So I want you to just please give us your, parting words that you want us to hang on to before we say goodnight. And
once again, thank you so much, Dr. for having me here, man. Thank you to the Medical Mondays community. It's always a joy to be here. I think the final point I want to make is the one that I started with, and that's the fact that suicide prevention is everyone's business. But I also want to encourage everyone who may not be a professional that even despite the fact that we are not professionals in the field, either mental or just that we're not even health professionals, we can still make an impact. We can still, there is something that we can still do to move forward the suicide prevention strategy in our remit. Every one of us is an influencer. We have power, and I encourage us to begin to think about how to use that power appropriately. Thank you very much for having me.
Thank you so much. God bless you. Thank you. Thank you. And I'm going to be getting in touch with you. We have work to do. God bless you. Thank you. Have a blessed night. Blessed morning in Britain. Thank you.